A healthy young adult develops fever after environmental exposure. Within days, the infection progresses rapidly to fatal sepsis, high mortality if not recognized early. The cause is Chromobacterium violaceum, a rare gram-negative bacterium, commonly found in soil and freshwater environments. Although uncommon, this pathogen carries a high mortality rate, occurs mainly in tropical, including Southeast Asia. Because cases are rare, diagnosis is often delayed or missed.
Chromobacterium violaceum typically enters the body through breaking skin, especially after exposure to contaminated soil or water. The bacteria attach to extracellular matrix proteins, such as collagen and fibronectin, helping them establish infection at the entry site. Host immune cells recognize bacterial components through toll-like receptors, particularly TLR2 and TLR4, triggering the innate immune response. Recognition of the pathogen stimulates inflammatory cytokine release, recruiting neutrophils to the site of infection. Despite the immune response, some bacteria evade destruction and survive locally, allowing the infection to progress toward bloodstream invasion.
After entering through skin wounds or contaminated water, Chromobacterium violaceum begins local tissue colonization and rapid replication.
As bacterial density increases, quorum sensing is activated through the violaceum, regulating virulence and pigment production.
This triggers expression of virulence factors, including violacein and secretion systems, that enhance pathogenicity. The type 3 secretion system injects effector proteins directly into host cells, disrupting normal cellular functions. These effector proteins inhibit macrophage phagolysosome killing and reduce reactive oxygen species-mediated bacterial clearance. This allows bacteria to survive. Once immune defense is bypassed, the bacteria enter the bloodstream, leading to bacteremia. This triggers massive cytokine release, including IL-1, IL-6, and TNF-alpha, leading to systemic inflammation and sepsis. The inflammatory cascade damages endothelial cells, resulting in vascular leakage, organ failure, and potentially fatal septic shock.
Upon localized colonization, the bacteria initiate a distinct pathogenic mechanism. Violaceum functions as a direct cytotoxic dysfunction and program cell death within host tissues.
Concurrently, hemolysins compromise cell membrane integrity, leading to the lysis of red blood cells. Secreted protease then enzymatically degrade the extra scaffolding of the surrounding tissue. To secure this, bacteria make a biofilm matrix. They inhibit immune responses, neutralizing neutrophils, and they suppress the oxidative burst pathway.
This localized cellular damage leads to the clinical formation of abscesses and focal tissue necrosis. As local structural barriers are compromised, the bacteria gain access to the vasculature, facilitating rapid systemic dissemination and advanced septic progression.
When a patient is suspected of having an invasive Chromobacterium violaceum infection, diagnosis begins with collecting a blood sample for laboratory testing.
The blood sample is cultured to detect bacteria in the bloodstream, allowing microbiologists to determine whether an infection is present.
Laboratory identification then confirms the organism as Chromobacterium violaceum, enabling clinicians to select the most appropriate treatment. Because Chromobacterium violaceum infection is extremely rare, it may initially be mistaken for more common bacterial infections.
Early treatment with broad-spectrum antibiotics is essential while laboratory results are being confirmed. Prompt therapy improves patient outcomes, whereas delayed treatment increases the risk of severe complications. Prevention begins with proper wound care. Any cuts or abrasions should be cleaned promptly and covered to reduce the risk of infection. Although infections are uncommon, Chromobacterium violaceum is an emerging environmental pathogen. Greater awareness among healthcare professionals and the public can promote earlier diagnosis,